since I was a child, I have always wanted to be a nurse, inspired by my mother, my role model, Mrs. Jemima Mutawazi. And look at the beautiful uniform. I see Lyra, Mbarara, all our colleagues in Mbale with a very nice uniform. I wanted to wear one of that. So she encouraged me and allowed me to travel thousands of miles to the United Kingdom to pursue my chosen career. I completed my training and qualified in 2008. And I have had the privilege of working in various capacities and clinical settings, including the private sector here in the United Kingdom. So slide 3, please. I would like to thank WHO and ICN for this opportunity through the Global Nursing Now campaign to play a part in raising the profile and status of nurses and midwives through this knowledge sharing platform. Now, due to the current pandemic, we are having our second conference virtual. I think it's a very good experience. It has proved to bring so many colleagues from all corners of the globe to share learning. It's an awesome opportunity. So to give you a little background of why we are here, if you're not familiar with the knowledge sharing platform, I have a slide I would like to share with you. Bear in mind, it is not very, it's a warning slide. I'll let my IT team share the slide with you. Slide 4, please, team. The picture of my late grandmother, rest in peace. It's a slide, a stage 4 pressure ulcer, which normally we would see on the wards called a chiwundu. But unfortunately, it's just skin breakdown. So the next slide, please. So where we are is starting the journey of the National Healthcare Conference. We are now in the second conference, and it has been a very good journey so far. The idea is to outsource experts in different nursing fields to come and share that knowledge with us. Would like to thank all our generous speakers who have taken time to prepare and share their knowledge with us today over this conference. We are thrilled to have our national and international speakers, and this year our key guest speaker, Thomas Serena from the USA, who is just getting ready to go to bed. It's 2:30 a.m. So thank you very much. Please allow me to thank a few individuals and stakeholders who have made this second a reality. I'd like to acknowledge the First Lady and Honorable Minister of Education and Sports, and Honorable Rosemary Seninde, her representative today. Permanent Secretary and the Ministry of Health team, including our new Commissioner of Nursing and Midwifery. His Excellency, the Ambassador of Uganda to the United Kingdom, Mr. Julius Peter Moto, and one of my outstanding mentors, Dr. Rose Clark. The leaders, Nurses and Midwifery Leadership Think Tank, and essentially the chair, Commissioner Dr. Safina Musene. Our Nursing Now campaign coordinator, Mrs. Catherine Odeke, and Miss Judy Africa. I pay tribute to ICN, our guest speakers, Dr. Catherine Hanaway and the Northern Ireland team, our judges this year, led by Miss Rose Chiwanuka, and the team behind the 2020 conference. I would also like to thank these organizations and groups, the Ministry of Health, Seed Global Health, Country Director, Mr. Boni, and the Nursing Technical Advisor, Ms. Irene Atuharire, the Board of Directors at Banded Trust of Nursing, who brought the Nursing Now campaign. I would like to thank Uganda UK Health Alliance, led by Mr. Dr. Henry Muonge and his, for this conference, mainly our IT lead, Mr. Timothy, who is doing all the technical support in the background. The Commonwealth Nurses and Midwives Federation, the Nursing Now board members, the National Healthcare Conference board members, Zone 1 hearing, Nursing Now Uganda as a whole, JAPEGO, Impact, Continued Education Alliance, Amorphil National Healthcare Trust, CIFOVID Uganda, the iHealth Africa Foundation, and Nightingale Challenge, the young nurses and midwives leaders. I would also like to thank these hospitals, their management and SPNOs at the regional referral hospitals. I see Port Poto already logged in, Lira, Arua, Mbale, Ruaga, Mulago, Mbara, Masaka, Iganga. We have really tried and we really appreciate your leadership. And all the executive directors, especially Dr. Andrew Sekitoleko. Love to also thank the media houses for helping us to promote the nurses and midwives in the country, including Monitor Publications Limited, KF Station, CBS, UBC, Beat FM, and so many more. Last but not least, to my colleagues, those who are going to present their research, those who have sent their questions ahead of time, and those who are participating and have joined us on this virtual platform. We hope the conference, and that most importantly, you live here enthused with new ideas and contacts to take back into your practice. On behalf of the National Healthcare Conference 2020, thank you very much. And I hand over now to our coordinator, Madam Catherine Odeke. Thank you.
Good morning.
Good morning, Sister Catherine. We can hear you.
Yeah, this is Catherine. Yeah. For protocol purposes, guest of honor, our Honorable Minister of Education and Sports, First Lady of the Republic of Uganda, Mrs. Janet Kataha Museveni, all invited guests and all guest speakers, nurses and midwives who have called in. My topic is really on globally, nurses and midwives contribute to 90% healthy workforce. And in Uganda, they contribute to 73%, which for me, I believe it is even more than that. Nurses and midwives are getting to do more activities that previously were done by only medical doctors. And this can be more exciting and motivating when what they are doing is recognized and their policies and scope of practice to protect and cover them in that which they practice. Raising their profile and building their status will demonstrate what more they can achieve and will enable them to maximize their contribution. And also it will help that in a way that the uncomplicated, non-communicable diseases can be taken care of in nurse-led clinics and lower health facilities. Nurses are a bridge between communities and health institutions, and that's why their role in universal health coverage is crucial. This one is a quote from the Director General of World Health Organization. Also, to improve health globally, nurses and midwives can do more when enabled. We have 24 million nurses and midwives globally, but unrecognized asset that can be developed to have greater impact in healthcare provision. Nurses and midwives will contribute to improved gender equality, as the vast majority of them are female who build stronger economies. Have a lady, as the saying goes, educate a woman and you educate a community. When you educate a man, well, you may educate a community, but you may educate an individual who will just to develop, but women think beyond and they empower other women and they build other young women to come up and also rise up. So this is quite good. There's need for more, or for those who already have, or just there's need for specialized nurses and midwives to handle specialized cases such as cancer, cardiac kidney diseases, newborn conditions, and children's conditions. Also, it ensures opportunities for leadership development, higher education, and other professional development. Specialization gives care, the career development. And then in areas of education, research, a nurse or a midwife can advance as a specialized nurse, consultant, senior consultant, up to the level of professor, just like medical doctors do. Other than all nurses waiting to advance in leadership management positions, which are quite limited. The changing needs of the 21st century mean nurses and midwives have to play new and innovative types of services to meet these needs in the home-based level, more in the community, holistically, and people-centered. Increased focus being on prevention and making better use of technology. The changing needs of the 21st century, for example, okay, that one we have already done it. And then now in Uganda, Nursing Now campaign has been embraced by majority of nurses and midwives. There are committees put in place to run the activities of the campaign, appointed by the Permanent Secretary, Minister of Health, who is also the overall leader of the campaign. The committees are derived from the key thematic areas of the professions of nursing and midwifery. That is clinical practice, education, and regulation. Leadership, policy, and governance cut across all this. With support from our chest, we are working on our fourth thematic area. To see the next slide, okay. Okay. We are working on the fourth thematic area, which is in progress and almost coming to conclusion. That is the Nurses and Midwives Federation, that's the association. That's our key, the other fourth key thematic area. We also blessed to have Professor Massa Francis, who is on the Nursing Now Campaign Global Board and is on our advisory committee. So we just get a very good further advice on our Nursing Now campaign. Concluding forming of the Nurses and Midwives Association, this is our way forward now. We are to conclude on the formation of our Nurses and Midwives Association. We are to continue documenting nurses and midwives success stories as more are coming out right now, and continuously profile exceptional nurses and midwives and advocate for scaling up of the activities. Mobilize funds for training of nurses and midwives on advocacy and transformation process. We also think looking at mobilizing funds to support operation of the Nursing Now Secretariat, support professional development, peer leadership, and mentorship. Thank you very much. I'm done.
Fantastic. Thank you, Mrs. Odeke. That was fantastic. We really enjoyed your presentation. So just a little bit of housekeeping. Can we please request that all participants mute their microphones unless they are actually speaking, because it just affects the sound quality. And we're now entering into a 5-minute comfort break. After the break, our Nursing Now campaign song will be playing. So that's coming up shortly. It appears we're having some issues playing the Nursing Now campaign song, so we would like to hand over to Dr. Thomas Serena for his keynote speech. Over to you, Dr. Serena.
All right, thank you all very much again. And it looks like we have our screen. Hopefully everyone can see the screen. What I'm going to talk to you about this morning is surgical site infections and prevention and diagnosis. And in addition to that, I'm going to talk about some newer technology, and I'd really hope to bring that with me when on my visit. And I pray that that will happen in the future. So, let's see if I can get this thing to move. Righty. There we go. Surgical site infections have been common since the time of surgery. And just so everyone knows, I am a surgeon and a general and vascular surgeon, although most of my practice now is in surgical site infections and wounds. But it dates back to many centuries, and we all know the stories of trying to get surgeons themselves in the operating room just to do something simple like wash their hands. Bacteria is very interesting, and I spent most of my life studying these little creatures, and there are some definitions that are important for us to know. Contamination, that's the bacteria that's on all of us and sitting on the tabletops and everything else. It really doesn't do us any harm or put us in any danger. Colonization, typically we talk about that on our skin, in which the bacteria are present, but they don't invade. They're not attacking us. They're not invading the host. And then at some point, the bacteria change their mind. They decide that they should become angry bacteria, if you will, or pathogenic bacteria. And they begin to invade the host, and they begin to produce proteases, these molecules that will cause the host to break down and invade that host. And if we don't intervene at that point, then ongoing infection will occur. So this is a big problem. Mortality following abdominal surgical wound dehiscence or infection can be very, very high. I did a lot of thousands of abdominal procedures in my career, and I still treat a large number of patients that have abdominal wounds. In cesarean section, it can be as high as 8 or 9%. That's very apropos for our group this morning. It's an interesting thing, and this is really true in the UK, in the US, that the surgical site infections are really born in the perioperative period, but they don't appear there. They don't present there. They present in the home setting, and in our case, in the wound clinics. We have wound clinics that stretch across the United States and the world. And although the operation is done in the surgical suite in our operating theater in the hospital, we tend to recognize the infections when the patient's already left the hospital. And so I thought when I'd left surgery to do just wound care and surgical site infections, I thought maybe I'd left that, but that's not true. So some definitions that are important, and that is that surgical wounds can be classified as clean, in which you just you do a surgical procedure, but there's nothing open. There's no drainage from any organs, and the infection rate there is very low. In this case, like a hernia surgery, that would be 1 to 3% risk. Then clean contaminated, in which you may enter the bowel or another organ, but there's no break in technique. Contaminated wounds are where there's gross spillage, usually of bowel or purulence from something. And then dirty wounds are just, this is the one where someone has perforated their colon, say from a disease like diverticulitis, and the abdominal cavity is completely filled with bacteria, purulence, stool. And they have a very high risk. And most of the time in the contaminated and dirty wounds, the surgeons don't close the wounds. They purposely leave them open, and then we often have to take care of them. The World Union of Wound Healing Societies has graded the wounds. I'm going to, all these slides will be provided to you, so don't worry about scribbling anything down. I will give them to the committee. But this is a fairly new grading system, and you can see it's based on how deep the wound is. And the World Union has decided that based on the depth of the wound, we can grade the wounds. Why is it important to have a grading scale at all? Well, when we talk across the world, we need to all be on the same page. We need to understand what we're saying to each other. So if you say to me, well, someone has a stage 2 wound, I know exactly what you mean. It's a wound that's through the skin and in the tissue below the skin, but there's no exposed deeper structures like the abdominal wall fascia. So why do surgical site infections and dehiscence of the wound occur? Well, there are three basic factors. One are the patient, two, surgical technique, what happens in the operating room, and three, perioperative care, what we do right before surgery, and then more importantly, after surgery. So there are a large number of patient factors that go into the development of surgical site infections. Diabetes is probably number one. Weight loss and malnutrition, the use of tobacco. As we get older, we don't heal as well. That's obvious. Patients in the abdominal surgery who have ascites or liver failure, anemia, renal disease, if patients that are on steroid use for other diseases, and then if they've had radiation or chemotherapy, all of these things contribute to the risk that the wound will break down after the surgical intervention. Take a closer look at diabetes, and this goes back to a time in the United States when the heart surgeons the government told the heart surgeons that they were going to publish the number of surgical site infections that occurred during their median sternotomies for coronary artery bypass surgery. And so the surgeon said, well, we better take a close look at this. And it turns out that when they took a close look, diabetics were the most common patients to develop surgical site infections. And it was directly related to their blood glucose levels. So the higher your blood glucose level, the more likely you were to have an infection. So you can see on this chart here, if your blood glucose is greater than 300, wow, 15% infection rate. But if you can drive that glucose rate down to less than 200, it's 5%. A friend of mine and colleague recently underwent bypass surgery. He had a terrible diet, and he's a diabetic. And they put the cardiothoracic surgeons put him on insulin. He was not an insulin-dependent diabetic, but for the month before his elective bypass surgery, he was placed on insulin to drive his blood sugar down so that he wouldn't get surgical wound problems. Nutrition, we all know, is also very important. We want our patients to take a high protein diet before elective surgery. And there are many surgeons across the world now that are supplementing the diet. We do this a lot in our clinic. Primarily, I don't use a lot of supplements right now. Maybe I should, but what I usually do is dietary education, telling folks, let's focus on the protein aspects of the diet as we anticipate surgical intervention. And bacterial burden, how much bacteria is on the skin? And we spend a lot of time cleaning off the skin. And our nurses, my nurses do they just do a fabulous job at cleaning the skin. Now I'm going to explain the technology you're seeing here. You see all that red? That red indicates bacteria. And this is the camera image that I'll describe for you shortly. But that red indicates a large amount of bacteria, far more than bacteria than would be required to have an infection. The second aspect after patient factors would be surgical technique. And this includes hand washing, wearing double gloves in the operating room, obviously observing sterile technique, as all surgeons and nurses are taught, clipping rather than shaving the hair, preparing the skin and getting rid of all that red you saw there by scrubbing with an antiseptic. In colorectal surgery, we give the patient a bowel preparation ahead of time. And then if you have a break in technique, you change your gloves and instruments as well. These are techniques that the nurses and doctors are taught in preparation for going to the operating theater. The length of time of the operation is also important. The longer the operation, the more likely you are to have a complication with a surgical site infection or just a dehiscence or separation of the wound. And then checklists. Atal Gawande is a surgeon in Boston where I practice as well, and he went through. He's introduced internationally this checklist. And if anyone wants this, I have a PDF copy of the book. And you just go through a simple checklist in the operating room. Did I give the antibiotics? Have I taken the right preparation for this surgical intervention? They're very effective. And then where I spend most of my time working on surgical site infections is in the perioperative care, the third factor. And this, we want to make sure that in cases that antibiotics are given prophylactically, they're given 1 hour before the operation. We want to maintain normal temperature during the surgical procedure. Many of the operating rooms are cold, particularly in Boston, and we want to warm the patient. After surgery, we continue to give them oxygen. This was actually developed by a mentor of all of us in the wound care and hyperbaric space, TK Hunt. I'm just going to put a little bit out there about selectively using negative pressure. This is another newer concept in trying to keep the wound edges together. And then something we're looking at a great deal lately, and this is new across the world, and that's what do we put on after we do the surgery? How do we cover that wound? So supplemental oxygen, and you can read this, and again, I will give you these slides. It increases the oxygen delivery to the wound after the surgical intervention, and this is important to prevent the base of the wound from becoming hypoxic and leading to surgical dehiscence or infection. And I'll go back to TK Hunt. He was a professor of surgery at the University of San Francisco in California. And after he had his own surgery, he in the recovery room, as he was waking up, he turned to his young resident and said, "Go get the oxygen and put me on oxygen. I have to have oxygen post-operatively." And a lot of our scientists now believe very strongly that this is a very important aspect to preventing post-operative surgical problems. And then I mentioned this already, warming the patient in some fashion. If the operating room is cold, we want to keep the patient about 36.5 degrees Celsius. Peri-operative antibiotics, again, we want to give the antibiotics within an hour of the timing of surgery, and that's what our checklist will have on to make sure that that's done. This is an interesting idea. It's fairly new, and I don't do it routinely yet, although some surgeons do in vascular surgery and complex abdominal wall surgery. And that is, you can put on a device that it's a very simple device, and it just sucks on the wound. And this is one of our experimental evaluations of it. You can see it's a foam and a piece of suction attached to the foam, and it exerts about minus 125 pressure, 125 millimeters of mercury. And what it does is it reduces the amount of tension on the surgical line, and that decreases the risk of dehiscence in complicated procedures. Don't use this on every patient, but we are looking at it, particularly on some of the abdominal wounds. And this is a pig study. That's not, looks like human skin, but it's not, it's pigs. And after 5 days without the suction on your left, you can see that the sutures are rather taut, they're tight. And on the right-hand side, you can see that the incision is much more relaxed and the incision looks much better. And this is after receiving the negative pressure. So it's just an idea that I want to introduce. It's something that we're looking at. And then lastly, post-operative dressings. You know, ideally, we want a dressing that's going to allow gas exchange, but not bacteria to get through. And we want to put something antimicrobial in it so that we don't get bacteria growing within the dressing itself. It may also have an insulating effect. In other words, keep the incision warm, but not too warm. And that's the ideal post-operative dressing. So when we're assessing the patient for infection, what signs and symptoms, what do we look for as nurses and physicians? We look for pain, and obviously that's a very important sign. Delayed healing, it may have a foul odor. There may be increased drainage, edema, bleeding. As you see in the picture, there may be some tunneling, the induration or toughness of the skin around the wound, and there may be bridging or pocketing, tunneling, as I've already mentioned. These are signs of infection in these post-operative wounds. The problem is that not all wounds, particularly the ones that become chronic, will have the classic signs, rhubarb, tumor, calor, dolor, as we learned in school. They don't have those classical signs and symptoms of infection. And in a lot of our patients, our elderly patients and others, they may not be reliable. So we look at what are reliable signs of infection, and you see that foul odor, wound breakdown, increasing pain, all very important. And this is some studies done by one of the nurses in the U.S., Sue Gardner. We are just publishing today. It's really very exciting for us. We're publishing the use of this camera and the validation of this device. I'll show you in just a minute. In over 350 patients. This study was done entirely in the US, although there are studies being done globally. What we found was that in many times the nurses and doctors can't make the diagnosis accurately with the use of just your vision. So, and that's important. And you can see right in the middle of the slide there, it says SSI, surgical site infection. And the investigators, including me in this study, were only accurate about 10 to 15% of the time in making the diagnosis of a wound that was becoming infected. It's not easy to do. We use clinical examination, plus we need additional tools. I'm just going to share this with you. I hopefully I will get to bring a camera with me someday, and we can have a lot of fun and study this together. But very simply, this is a camera, and it shines a light on the wound. It's a violet light at 405 nanometers, and you don't need to know that, but it's very violet. It's almost, but not quite ultraviolet. When you shine a violet light on a wound, the bacteria in the wound absorb that light and then emit their own light. The light that they emit is usually red, although Pseudomonas is a little different and it has a cyan color. The filter in the camera then will pick up that red fluorescence. And if there's too many bacteria in the wound or on the skin around the wound, then you will see this fluorescence. It's very simple. If you can use a phone, you can use this device. So this is just some examples and some chronic wounds and one surgical wound. You see on the top is just a regular picture, and it's basically a picture from an iPad, which is the base of this camera. And then on the bottom, you can see that we have red fluorescence, and most bacteria will give you this red color. The one exception is Pseudomonas, and Pseudomonas gives you a cyan or a halo type color. If you look at the bottom right picture, you see how that bright sort of white appearance is. That's Pseudomonas, and it has a slightly different fluorescence, and there's a reason for that biochemically, but I'm not going to go into that right now. We can talk about that at some other point. In addition to detecting bacteria that are just in the wound, we call those planktonic bacteria. It also finds biofilms, and this is very important in wounds because wounds get a biofilm, a thin layer of material that the bacteria produce and then hide in. And it's very difficult to treat the bacteria when they get into this biofilm form. You can see those large numbers of bacteria that we have studied that will fluoresce the red color, including anaerobes. Now, what happens if we add this camera to our clinical examination, all those signs and symptoms that we talked about previously? If we add signs and symptoms plus this procedure, we rapidly improve our ability. So we went on the surgical site in the middle, there's SSI. We go from 10% of the ability to see bacteria all the way up to over 80%. And it definitely increases our ability to see if that wound is infected. Here's just one of my patients, and I looked at the image on the left, the standard image, and I said, she doesn't have an infection. There's no problem here. And so I'm not going to treat her with anything that might be reduced infection. And in fact, I'm going to confess something. I had told the nurses to hurry up and get the patient treated and put the dressing on because and stop cleaning off the skin around it. My nurses are so good at cleaning the wound around the wound or around the incision and doing a very good job of cleansing. And I was moving them along to try to have them get to the next patient. And when I took the picture, I realized that I was incorrect. Now, the wound itself has lots of red. It's infected. And look around it. Look at the top where the arrow is in that picture on the right-hand side. That is enormous amounts of bacteria on the skin. So I was wrong and my nurses were right. And now I don't do that anymore. I tell my nurses, clean the skin and I'll wait. Or I'll help you clean the skin, because it's very important to keep the skin clean around the wound, whether it's an open wound or a closed incision. All right, so I am one of the board members of the International Surgical Wound Complication Advisory Panel. Wow, it's a long word. It's easier just to say ICECAP, and that's what we call it. And there are a number of best practice statements that we've published this year, actually. And the ICECAP is working towards diagnosing and treating wounds more effectively across the globe. It's actually based in Australia. Statement number one is to follow your local plan for peri-operative and post-operative care. These are all the things I mentioned: maximizing the patient factors, having good surgical technique, and good peri-operative care. Statement number two is to introduce management and prevention policies, and there are a lot of these around, and I'm happy to share any that you'd like to see from the World Health Organization or other organizations. Statement number three is that we should assess and treat the wounds looking for surgical site infection. Statement four, and I think this is probably very important for our group this morning, and it's really essential, and that we must have a multidisciplinary team. It can't just be doctors. It's got to be our fabulous nursing nurses as well. And it needs to be multidisciplinary. We need to have physicians, surgeons, and nurses, nurse midwives involved in this care. This is something for everyone. Statement five is we want to try to find the cause of the infection, if there is one, and use the appropriate antibiotic care. Statement six is let's not avoid novel strategies like telemedicine and new diagnostic tools like the one I just mentioned, which is basically not too dissimilar from a smartphone application. And I think that the one thing that COVID-19 has taught us is that the time for us to do telemedicine and remote education, just like we're doing right now, it's here. It's here, and we need to continue to share our knowledge across the world. Number seven was that we should document and collect data on surgical site infections, no matter where they are, and that will help us, and we'll learn that way. And statement eight is really just about conducting research in order to expand our knowledge and evidence-based practice on the prevention and treatment of surgical wound complications and the treatment of open wounds. So the last statement really is relates to back to our phones, back to telemedicine, and that is that the outcomes of what happens when we diagnose surgical site infections, what happens when we use the camera that I showed you earlier. We need to track them, and we have a number of apps that do that very nicely. We have a study right now, a global study on COVID-19, and we're using the app that you see on the screen there. It's very similar to that, and it's an app that you just download on your phone, and you can upload data or download information. Very simple to use, and it allows us to collect data no matter where we are in the world, and share knowledge back and forth. All right, so I'm going to end here. We are huge fans of this technology of doing things virtually. We don't have to be everywhere any longer, and I'd love to work with the team. That's how I initially became acquainted with Elizabeth. And I said to Elizabeth, let's do a trial together. Let's continue to look at the problems of why wounds fall apart and why wounds get infected, and can we do anything about it? Can we intervene? Can we introduce some of this new technology, which has become so simple because it's something we can introduce with camera technology that is, for the most part, pretty widely available. And with that, I think I will pause, and I think the questions are are going to be in the panel discussion, but I will leave that up to our moderator.
Thank you, Dr. Serena. That was absolutely fantastic. I learned a tremendous amount there. And I think not the one takeaway, but one was how, the eye isn't that reliable, and these fantastic new diagnostic tools can help. So thank you again so much for that. We look forward to seeing you in the flesh in the not too distant future, although we are loving this technology.
Thank you.
So now we're going to hand over for our Q&A session to Mr. Edson Monday. And also, due to a couple of technical issues, we were unable to admit everybody we wanted onto this session. So after that, we've got Judy Cagnola, who will be coming on to present. But at the moment, we're going to hand over to our moderator, Mr. Edson Monday. Thank you, sir. Okay, we seem to be having a couple of issues with the Q&A. So what we'll do, we'll hand over to Judy Cagnola, and if we're able to, we'll go back onto the Q&A. Thank you very much.
Yes, thank you, Dr. Serena Thomas, for the nice presentation. This lesson, right from Lira Regional Power Hospital, Uganda. Once again, thank you for giving us this good knowledge about wound care. And so I would like to take only 3 questions from all the listeners all over the world, particularly in Uganda. So I want to give a chance to the audiences, wherever you are, please give us only 3 questions. Any question?
I actually have a question for Dr. Serena. Thank you, Dr. Serena, for your presentation. My question is how adaptable is the technology for low-income countries? I think that is what most people here would like to know. How do they access that? How adaptable is it? What is the learning curve for surgeons and nurses in low to middle income countries? Thank you very much.
Thank you for the question, and thank you for the kind words. This technology now is dropping in price, just like all cell phones and everything else. I think our goal is to make this technology available to low and moderately income countries. That is part of our plan, and we are raising funds right now to make that happen in Africa and into China. It's important technology. I think it needs to get in everyone's hands. It's very easy to use. If you have used a phone, you can use this device. It's incredibly. It's really nothing more than a phone app with a special filter. And so, our goal is to make this available across the globe. So it's something that our group is working on, and hopefully we'll all be able to work together in introducing this type of technology in Uganda. And that would be certainly something we'd be very interested in.
Serena, I would like to know more about how oxygen supplementation post-operative will help facilitate wound healing. Probably here we may not look at that in Uganda as something serious that every patient maybe has had surgical incision needs to have oxygen supplementation. How does oxygen facilitate wound healing post-operatively?
We supplement oxygen, and I want to be clear. There's still some controversy about it. I'm a firm believer in giving oxygen in the peri-operative period, right after surgery. And the idea is you hyperoxygenate the tissues. I do mostly abdominal surgery, so I'll speak to the abdomen. You oxygenate the base of the wound. In the depth of the wound, you increase the amount of oxygen. that's how the white blood cells kill. They concentrate oxygen into free oxygen radicals, and that's how they kill. So what you're doing with the oxygen is enhancing the body's own immune system to fight infection, and that's the theory behind supplemental oxygen in the perioperative period. So if it's available, I think it's advisable. There's a couple questions just coming up on the chat. I'm just going to try to answer them. They're going too fast for me to read them all. But we do note that some folks said, how often you take the photo, the image? Wow, that's a great question, and I should have answered that. So with the camera system, we generally image shortly after we see the patient, and we're worried about infection, and then I will institute some topical antimicrobial or some other debridement dressing technique, something, and then re-image. Usually it's a week to 2 weeks. I don't image them every day. Although it's very simple. It really is just a camera. And but you don't want to image them too soon. It takes about 2 to 4 weeks to get rid of all that bacteria on the skin in a chronic infection. And in more of acute infection, it takes about a week to 2 weeks. So there's no reason to image it before that time. There was a ringing noise. It was really hard to hear what they were saying, but I think that it was how easy it would be for that the technology for Uganda. It's actually, like I said, it's very simple technology. We're working right now to even simplify it, to make it even easier and very available to really available to everyone. There is someone asked about learning to read the images, and there is some. It takes a little time, not a lot of time. You need to do a number of cases before you really get good at reading the images. But we have lots of our nurses are very, very good at that, and are more than willing to help in teaching folks how to do it. And this is not, don't need to be there. This is all online. You can access it and learn how to use the system, and you can always send me a text message if you have a question, or one of my nurses, and we'd be happy to answer that when we get that far. Someone asked too if it does it expire? No, I've had mine for several years already, and I've taken thousands and thousands of pictures on it. It's still going. In fact, it's sitting right over here on my desk, and still going like crazy. And it was the first one that's ever been used in clinical trials, and it's still as good as it was the first day I got it. It's very tough. We don't want you to drop. We don't want our folks dropping it, but I've dropped it a number of times. It's very resistant.
Thank you so much, Dr. Thomas, Serena, for the nice presentation. We've actually been able to learn something from this, and we pray that we will have this brought down to the ground in Uganda. We want to go through the same procedure in Uganda. We want to care for our wounds in Uganda, and probably see patients take less time in the hospital. They don't have to stay long in the hospital simply because some of the things we do probably we don't observe the 9 steps you explained. Thank you so very much. Unless there's any other questions for the members, say bye.
Okay, so thank you, Edson, and also again, just thank you, Dr. Serena. That was fantastic, and we really hope to see you in the flesh very soon. So due to some technical issues earlier, we were unable to get Judy Cagnola on, but fantastic now to say that she's on, and we're going to hear from her next. Thank you very much. Over to you. Okay, I think next we're going to hand over to Rose Chiwanuka, the chief judge this year, and we're going to look at the oral abstract presentations because we still seem to be having a few technical issues. So over to you. Thank you very much.
Okay, my name is Rose Chiwanuka. I'm a palliative care nurse, and I've been in palliative care for the last 27 years. And I'm happy, I think, to moderate the next session. Is that right?
Yes, please.
Thank you very much, Elizabeth. So our next presenter, when I look at the program, it says we are going into oral presentations. So the first presentation is going to be drug resistance, TB, at the TB Clinic Mulago National Referral Hospital. And that is by Mr. Connie Olwen, Makerere University. Could we have them, please?
Okay, thank you. Protocol observed. Good morning, everyone. I'm by the names of Ranga Charles, BSN from Makerere University, and currently doing my internship at Kabale Regional Referral Hospital, representing our team, me and Miss Connie Orit. I submitted this abstract as category 2 of management of infectious diseases. And this study was done in 2019 when I was doing with the topic of living with multi-drug resistant TB at Mulago National Referral Hospital. May we go to the next slide, please? So resistance to major anti-TB drugs is a major global problem that threatens progress made in TB control and management. TB patients may be resistant to 1, 2 or more anti-TB drugs, and a form of TB resistant to isoniazid and rifampicin is what we call multi-drug resistant TB. In the year 2017, more than 558,000 new cases were reported globally resistant to at least one anti-TB drug. And more worrisome is the fact that 82% of these people had MDR-TB. And in Uganda, we had about 489 new cases reported in the year 2016. MDR-TB is a complex disease which requires treatment for at least 3 months, as opposed to the non-resistant TB, which requires only 6 to 9 months. And treatment can go to could go as far as 36 months, depending on how someone has healed. And the treatment is associated with severe side effects, more drug adherence issues as compared to the non-resistant TB. And during the time the study was being designed, there was limited literature in regards to the subject. We can proceed to the next slide. Okay, here we are. So in Uganda, we had a high number of MDR-TB patients, and their numbers was inconsistently fluctuating every year. And secondly, we had high mortality rate of 18%, with a low successful treatment rate of about 74%. This meant that the strategies put in place to prevent anti-TB resistance. Someone to mute that. So that meant that strategies put in place to prevent anti-TB resistance and management were still challenged. And this performance could be linked to the side effects of the drugs, the high pill burden, frequent visits to the clinics, stigma in their communities, discrimination, trauma by the clinical manifestation of this disease, as shown in the studies which had been done in other countries. But however, we could not absolutely generalize findings from other countries due to the different social demographics and different socioeconomic standards of different countries like Uganda and India, Uganda and Philippines, where the study had been done. And the objectives of this study were to describe, to explore experiences of patients living with MDR-TB with specific objectives, describing experiences of these patients, and to identify recommendations on how health workers could help them cope with the challenges they undergo when they're on their treatment. It followed a descriptive qualitative study done among outpatient Mulago National Referral TB Clinic. It included those who had been on treatment for 18 months and more, and those who were critically, we can proceed to the next slide of methodology or methods. So this study included those who were on treatment for 8 months and above, and these were considered because we thought these had completed the initial phase of treatment, which involves injections, oral drugs, and now they're on oral drugs, so they had enough experience to share with us. We excluded those who were critically ill during the time of data collection. We used in-depth interviews, recorded, and later analyzed them using the content analysis process. We used data, we used a sample size determined by the principle of data saturation, by sample until saturation and redundancy is achieved. And this was achieved after sampling 25 patients. And we used purposive sampling method. Data was kept carefully, and we analyzed the data using the content analysis, the inductive analysis. And clearances were obtained from LAGO Research and Ethics Committee, as well as Makerere University Health Sciences Institutional Review Board. Let's go to the results of the study. Next slide. So, findings of our study showed that majority of the patients had been on treatment for 11 to 12 weeks, and the rest were equally distributed, those who had been on treatment for 8 to 10 months, 15 to 16, and 17. And after our process of data analysis, we identified, or we came up with 3 themes. One was diagnosis and treatment, during treatment, and social challenges these people undergo when they're on treatment. Treatment and diagnosis motivate us to seek for care or to seek for treatment. We had media, we had friends, we had manifestation, and so many other things. Reactions to diagnosis. Here we had, how did they react to the diagnosis? And we found that these people had many reactions. Many thought they were going to die. Many wanted to commit suicide. Many wanted to do so many things because of the diagnosis. And then we had medication-related side effects. And here we had the side effects of the drugs, like the nausea, the vomiting, the painful injection site, inability to walk due to the very many injections given. And these patients got support when they were on treatment.
Mr. Luanga, probably you could.
Okay. So we go to the last slide. Our last slide, we have the recommendations. So in our study, we recommend that we as health workers, we need to incorporate the concept of anti-TB resistance and anti-TB resistance and hygiene in our routine teachings to our patients. We need to provide psychological support to these patients. We need to remain unidentifiable when we go for outreaches or follow-ups to these patients. And we need to improve our communication skills when we are attending to these patients, as well as engaging the family in their care, because we realize that family is very fundamental in supporting these patients when they are on treatment. To the researchers, we need to look into treatment modalities. For MDR-TB, we thank God, at least in 2019, Ministry came up with a new treatment guideline, which has a shorter regimen, a shorter duration, and we are eliminating the injections. And also, we are telling the policymakers and
Mr.
the partner
Lwanga, time up.
organizations. Okay, thank you so much for the platform given.
Thank you very much, Mr. Lwanga, for that good presentation. Very informative. I would like to request members to please observe time. You know, we are time barred, so let's stick to our 7 minutes. I would like now to request the next presenter to come on, and we are going to hear this presentation on prevention of surgical site infection among mothers before, during, and post-cesarean section in obstetric and gynecological ward at Fort Portal Regional Referral Hospital. This is by Achaye Gladys and team, and I would imagine Achaye Gladys is the team leader, the principal author. There is Kemi Hendo there.
Let's have Rachel.
Okay, let's go to presentation number 3, which is knowledge and practices of in-school adolescents, girls regarding menstrual hygiene management in Karapo Parish, Lira District. And that is by MS Oboni, Jackie Patience. Is Jackie there?
Yes, she is here.
I think Jackie is experiencing problems with her mic.
So should we go to the next presenter then as they prepare? We'll come back to them. Our presentation number 4, which is assessing adherence of hospital staff to infection prevention and control guidelines in a regional referral hospital in Uganda. And that is by Winfred Mbabazi. Winfred, are you there? Winifred, do you have your slides? Maybe you could start speaking as they prepare to flash the slides, or you could share them.
The slides are on the computer which we are using for Zooming. I don't know how I can go back there.
If you have your slides on your computer, please start giving your presentation. Let us now engage the reverse gear and see whether we have Achayo Gladys on the line. If you're there, just say you're there, and then we can see how we get the slides shared. Is Achayo Gladys online?
Yes, she's there.
Okay. Are you ready to present now? Great. Yes, Achayo Gladys, the floor is yours and you're welcome to give your presentation.
Good afternoon, everyone.
Good afternoon, Gladys.
Yes, this is Gladys from Post-operative Regional Referral Hospital. So we are presenting an experience about the surgical site infection. That is the prevention. In a prevention of surgical site infection among mothers, before, during, and after cesarean section in obstetric and gynecology ward at Post-operative Regional Referral Hospital. This work has been a success with effort from gallant health workers. From gallant health workers, team leaders. I'm the team leader. The next slide. First, go to the other slide. I, Gladys, as the team leader. We have Chomoendo Bridget, who is a midwife attached to maternity ward. We have Kemuendo Hannah, is a midwife attached to medical ward, to maternity ward. We have Namiru Raquel, is a midwife and a wound specialist. We have Dr. Abeliko Lawrence, is a gynecologist attached to maternity. We have Innocent Arenaitre, who is our senior anesthetist. We have Alex Adapo, who is the hospital director. The next slide, please.
Gladys, please use your 7 minutes. You have 7 minutes.
So in the background, we conducted a prospective cohort study involving 1,836 mothers who were done cesarean section in July 2018 to June 2019. Out of these, 18.3% of mothers who had cesarean section got surgical site infections. And you're well aware that this presents a risk for increased maternal mortality and morbidity. Actually, maternal mortality is the second cause of sepsis, is the second cause of maternal mortality in Buyinga Hospital. So we have dissatisfaction of patients, longer stay hospital stays, high treatment cost, and antibiotic resistance. This one comes as a result of surgical site infection. So we set out to reduce surgical site infection from 18.3% to 1% by June 2020. So we conducted a brainstorming session with the entire team of health workers attached to gynecology ward and obstetric department. This is to determine the causes of surgical site infection following cesarean section. Using a fishbone method, we prioritize intervention to address late referral of mothers. We are referral hospital and we receive referral mothers from different health facilities due to obstructed labor, prolonged labor, and etc. And this poses a risk for surgical site infection. As we know, when a mother delays in labor, there are several vaginal examinations which is always being done. And we have identified that mothers who got surgical site infection in Fort Portal Regional Referral Hospital, normally they present with obstructed labor and prolonged labor. So we also address the low use of antibiotic prophylaxis, lack of antiseptic and disinfectant solution in the ward. We have congestion in the ward, lack of beds and poor beddings. Most of the beds we have are broken and the mattresses are torn up, and cleaning it is not actually being done well. So we have poor hygiene of mothers. This also poses a risk for surgical site infection, as we all well aware that in developing sepsis, we have the causes, which is the exogenous and then the endogenous microorganisms. So when a mother has hygiene is lacking, also it poses a risk for surgical site infections. So frequent vaginal examination, sometimes it is not done under aseptic techniques, that is putting on surgical gloves. So we have lack of supervision to junior staffs. Fort Portal Regional Referral Hospital is a training institution. So we have students who need supervision, and failure to supervise them, they always mess up. We have knowledge gap in infection prevention and control, and limited surgical equipment, as our number of cesarean sections are always high. So we had to do the interventions we have done is, we had to do on-site mentorship and training of lower health facilities on early identification and referral of mothers with sign of complications. Under this mentorship and training of the lower health facilities, we have done so many that the list cannot reach there. We did mentorship on the nurses and doctors attached to health facilities. Also giving of prophylactic antibiotics to all mothers who are going cesarean sections were done. Timely requisition of drugs and sundries to address the issues of the drug stock out and sundries. Then limiting the numbers of attendants on the ward, as we have seen that overcrowding also poses a risk of surgical site infections in the ward. Increased number of medical officers. Before, we used to have only one medical officers, and if there are around 10 cesarean sections done, this make the medical officers exhausted and fatigued. And you know, when you are exhausted, you would not be able to perform to the expectation. So we added more medical officers in maternity and gynecological ward. Of recently, we are having 5 medical officers attached to maternity and gynecological ward, as opposed to before, we were having only 1. Then we also did a training and mentoring of health workers on monitoring mothers using a pathograph. This will present frequent vaginal examination, as at least in the pathograph there are times whereby vaginal examination is supposed to be done. Then intensive supervision of the junior staffs were done. This one, the students were being followed and mentors to do the right thing in the ward. Ordering of surgical equipment from main store and partners. We had a partners of Knowledge for Change who has been helping us by giving us the surgical equipment, the beddings, and disinfectant solutions. Then training and mentorship of health workers on infection prevention and control, including hand hygiene, were also adhered to. And we managed to secure the alcohol hand gel to all the health workers in the maternity and gynecological ward, just a way that they can perform the hand hygiene. So the results, From July 2019 to June 2020, 2,793 mothers had cesarean section done. The percentage of mothers who got surgical site infection reduces from 18.3% to, that is in 2018 to 2% in July 2020. And this has placed a very good gap. We have reduced that surgical site infection and saved the mothers. So in the conclusion, go back. Yes, please.
Please give your conclusion.
So, in our conclusion,
Gladys, please give your conclusion. Time is not on our side.
Yes, the prevention of surgical site infection among mothers was achieved through a series of intervention, antibiotic prophylaxis and treatment, aseptic cleaning of the skin and vulvar swabbing, early referrals, limited vaginal examination were the most impactful. However, other interventions were also impactful. So we had a figure one, the percentage of mothers that develop sepsis, and we can see from the graph how the graph lowered from 18.3% to 2%, and the impact which has been created. Thank you. We are very sorry for the technical problem. We are very sorry for the technical problem. We are promised to address that one. Thank you.
Thank you so much. You will have questions at the end of the session. Could we now have Jackie? I understand, Jackie, you're ready. Please project your slides.
Hello. Am I being heard?
Yes.
Thank you very much. My slides are with the team there. I don't know whether they could show it.
The IT team, please help us with Jackie's slides.
But I can be talking.
Yes, please.
So the topic is knowledge and practices of in-school adolescent girls regarding menstrual hygiene management. And right now, I'm an intern midwife at Bulu Regional Referral Hospital. So I'm going to go straight to the presentation. So in the background, you see that adolescence is in girls. It signifies a transition from girlhood to womanhood. And during this period, and during this time, we see that girls experience menstruation. Now, menstruation is a normal physiological process, but in many parts of the world, including Uganda, there are certain tribes that associate menstruation with certain taboos and beliefs. And some of these beliefs and taboos that surround menstruation actually have very negative impacts on the lives of women and young girls. From past research, we see that there is increased risk of infections, especially reproductive tract infections. However, there is now a growing attention being given to menstruation to ensure that certain sustainable development goals 2013 are achieved, like quality education and good health, plus gender equality. So the objective of this study was, one, to determine the knowledge of these adolescents regarding menstrual hygiene. And then the second one was to determine the practices employed by the adolescent girls during menstrual hygiene management. Under the methodology, so I used a descriptive cross-sectional study, and I recruited 185 participants. These were all adolescent girls who had already attained MENAC. And I went to 3 different schools, 2 primary schools and 1 secondary school that were all located in Rapo Parish, that is in Lira district. So I used a predetermined, I used a pre-tested questionnaire that was self-administered, but then some of the schools, really the literacy level was low, so I had to go through question by question with the participants to enable them understand the answers and then answer very well. So after collecting the data, I entered it into SPSS version of 2020, the version 20 software, and I did the analysis. So under results, most of the participants attained MENAC between the ages of 13 to 15 years. Now, 97, and that is 52.4% of the respondents had a low level of knowledge on menstrual hygiene. And then about 83 had unsatisfactory practices. So I had a scale that helped me to gauge the practices. So I had unsatisfactory practices and satisfactory practices. Now, under the practices, this included bathing, how many times the girls bathed, how many times they changed their sanitary materials, and how were they disposing of the used sanitary materials. So then that brought me to gauge whether they had satisfactory practices or unsatisfactory practices. Now, the majority of these girls fortunately knew about menstruation before MENAC, and however, the sources of the information or where they were getting to know about menstruation was quite sketchy. Some of them got to know from their peers, others got to know from their teachers or older sisters. But from this study, the common sources of information regarding menstruation were from their mothers, and sometimes the school teachers who probably hit on it, but still, as they would speak, it's like, you know, there is that stereotype around it. The results also indicated that respondents use more than one menstrual type of absorbent, and most of them, pardon? And most of them used sanitary pads and reusable pads. Please, someone there, mute. Then in the conclusion, we find that of course, the knowledge and practices of these girls was low and not as expected. The information regarding menstruation was inaccurate and rare. Some of them had to get this information on the day they probably started the menstruation, and they would get it from a fellow girl, and the information they had was very sketchy and not accurate, which probably affected how they perceive the menstruation and how they deal with the menstruation. And let's go to the next slide, please. So under the recommendations from the study findings, it's obvious that these girls need more information and accurate information. So if we could set up health education programs and radio shows in the communities and schools to create more awareness on menstruation and menstrual hygiene management to the girls and their families, then they would be more equipped with the knowledge. Then we also have to still support the girl child with accurate information. And early enough, if these girls would be told about these physiological processes when they are from 8 or even before they start the MENAC, I'm sure it would really help them in managing the whole menstruation and removing the taboo and all that's associated with menstruation. Then others had problems or challenges getting clean menstrual materials to use. So in the study, there were some girls who actually used rugs, or they use toilet tissue, which is not safe and can predispose them to getting infections. So if we could explore other cheap and safer durable menstrual materials, and I looked into menstrual cups and reusable pads. So this would be cheap, but still safe for the girls. because with the sanitary pads, it's cheap but not affordable, and every month they would have to buy like 2 or 3 packets, which is not affordable there in the villages. So if you could explore the use of other menstrual cups and provide them to these girls, then I'm sure it would help them a lot and improve on their menstrual hygiene. Thank you very much. That's the end of my presentation.
Thank you so much, Jackie, for that good presentation and for teaching us what is happening, for letting us know what is happening in Opabo. Okay, I will request the audience to keep their questions, and we get to the next presenter, who is going to tell us about assessing adherence of hospital staff to infection prevention and control guidelines in a regional referral hospital in Uganda, and that is by Winnie Mbabazi. Mbabazi, the floor is yours. Thank you.
Thank you. Good afternoon, everyone. Can you
Mbabazi, please speak in the mic.
Yeah, good afternoon, everyone. Is it possible to project my slide? Yeah. Okay, we'll start, as maybe you are trying to project on my slide. The study I did was assessing adherence to infection prevention and control guidelines among healthcare in a regional referral hospital in Uganda. This was done.
Mbabazi, please speak in the mic. Be stable so that we can hear you.
Yeah. Okay, the background, the introduction, effective infection prevention and control guidelines is essential for providing high patient-centered healthcare and infection guidelines utilization and emphasize at all times. So healthcare workers have frequently been while offering care with the various and in Uganda, some healthcare workers have died from hospital-acquired infections.
Your network.
Can you hear me?
Be stationed there and people will hear you. Don't move.
Yeah, we are hearing. For continuous monitoring and implementation of infection prevention and control guidelines, the Ministry of Health has distributed guidelines to every regional referral hospital. But however, it has been noticed that the presence of these guidelines may not 100% guarantee the compliance and the use of these guidelines by the healthcare workers. So it was necessary that a study be done to assess the compliance. And the problem statement is that healthcare associated infections have remained a common problem worldwide. And according to WHO 2016, SAIs affect 5% of hospitalized patients in the US, and approximately 1.7 SAIs as estimated, and this increases the cost. And in Africa, healthcare-related infections are everywhere, between 2 to 20%, 20 times higher than in the developed. So, and in my literature, I looked at the literature in relation to the literature associated infections as a global cause, and the evidence that infection prevention and prevent healthcare associated infections. So the infection prevention and control guidelines for adequate personal protective wear protection, management, waste management, and proper sharp disposal. So then the literature also reviewed the compliance with infection prevention
mama mwechiri.
guidelines for related to the health belief contract. The method, a cross-section descriptive study design and COVID sampling were used. A total of 244 health workers were interviewed using structured self-administered questionnaires, and 3 participants were observed on infection prevention and control practices, and the 20 members in focus group. Compilation of data was done, and the SPSS version 16 used to analyze the results. Results: 17.5% respondents were seen to disassemble the needle from syringe disposal into the puncture-resistant container, and the sharp containers were filled beyond 3/4 before they were disposed of. 69.9 respondents from the 158 did not segregate their solid waste before at the point of generation, and 75.7% out of the 103 observed participants decontaminated waste by soaking them in 0.5 chlorine for 10 minutes and then washed in soapy water, which is good, then rinsed in clean water. But 24.3% did not decontaminate, and 64.1% used the sterilization tape for autoclaving. That means the 39.5% did not. And this means that we cannot say whether the sterilization has completely taken place if we don't use the sterilization tape. Masks were used, 16.5% only used, and even if were used, were not changed unless they were soiled. 50% of the participants reported washing hands at 5 moments of hand hygiene. But from the 560 hand hygiene opportunities that were observed, only 90 actions of hand hygiene were done. Non-availability of infection control materials, poor attitude of healthcare workers, poor reported things were other factors identified for non-compliance to poor IT practice. So in the discussion, compliance with infection prevention guidelines was inadequate and the correct practices were observed. There was inadequate knowledge for some participants, poor hand hygiene practices, and poor waste management. The most used protective gear were gloves, but only 16.5% wore gloves after washing hands. The majority
You need to summarize your presentation, please.
The practice was inadequate. So in conclusion, though a good number of participants demonstrated awareness about infection control, this study discovered there was inadequate knowledge and the prior practice in almost all aspects of infection prevention and control, such as hand hygiene, waste management, disinfection, and sterilization, as well as protective gear. Thank you so much. So as nurses and midwives, I think we really need to improve in the infection prevention control measures. Let us follow the policy, Let us follow the infection prevention and control guidelines to protect ourselves, to protect the patients we care for, and even in the entire community. Thank you so much.
Thank you very much, Winnie, for that good presentation and very informative. We are now going to move on to presenter number 5, I think. Yes, presenter number 5, I hope you're online, and that is integration approaches of palliative care into primary health care in low and middle income countries, a systematic review. And that will be presented by Diana, is the lead author. So please, Diana, get on the line.
Madam Rose. Hello, can you hear me?
Yes, please.
Yes, please. Kindly allow me to interrupt the schedule and take this moment to get the remarks from our chief guest, and then we can proceed with the abstracts. Is that all right?
Thank you very much for that information. The floor is yours, sir. Okay,
thank you very much. And ladies and gentlemen, as you're all aware, this event is supposed to be officiated by the Honorable and First Lady, Mama Janet Museveni, the Minister for Education and Sports. And she delegated the Honorable Rosemary Sendinde, Minister of State for Primary Education and Woman MP representing Wakiso District. At this moment, let me take the opportunity to invite her for her remarks and the official opening of this event. I thank you very much.
Because I could not hear the Honorable.
Can you hear me?
I can hear you now, yes.
Yes, I was proposing we get back to you, and when we can get that feed, the IT will advise how to proceed. Thank you.
Okay, thank you so much. And we need just to proceed to the next presenter, palliative care into primary health care in low and middle income countries, a systematic review. Diana, are you on the line?
Yes, I am. Are you projecting from there? Is my presentation being projected from there, or?
IT team, did you receive Diana's presentation?
Yes, Diana, I don't have your presentation with me. You can go ahead and present if you have the slides with you over there.
Okay, fine. Let me try sharing them. I think that might be an option. Are you able to see them?
Yes.
Yes.
Yeah. Slide,
yes,
slideshow.
Slideshow. That's what I wanted to do, but it doesn't seem to be coming.
In the interest of time, I'd request you go on.
Okay.
I think the IT team is doing something that they put it. Okay, Thank you so much, our IT team. I think we can see the slide now.
Okay. So, my name is Diana Basirika. I'm a palliative care nurse. I'm a palliative care nurse and a trainer working with Hospice Africa, Uganda. So I'd like to share my research about the integration approaches of palliative care into primary health care. This was a systematic review. As a reflection to this study, globally, there are 40 million people with palliative care needs. Majority of these are in low and middle income countries, and they are living with advanced diseases. They prefer to receive health care at home. But unfortunately, many of these die without role as nurses. Yet we are the backbone of palliative care. That is something to reflect about. The World Health Assembly in 2014 urged all governments to integrate care in order to improve access. It aimed at answering 4 questions. And these are: what low middle income countries or settings have integrated palliative care into primary health care? What approaches have been used to integrate palliative care into primary health care in these countries? And what has the impact been on the integration? What recommendations do these articles or do these studies give in order to accelerate the integration of palliative care into primary health care? So this study followed a protocol. Articles were searched from 5 databases, and 44 articles were retrieved from these databases. Of these 44 articles, most searches were done through the references of these articles, and 8 articles were bought. So a total of 52 articles were bought, and these were further screened following the inclusion criteria. So in the long run, only 11 articles were in line with the inclusion criteria, and these were the only articles that were included for the study. Data was extracted from these articles, and this followed a PHCPI framework, that is the Primary Healthcare Performance Initiative framework. Why did we choose this particular framework? That is because this framework particularly, this framework mainly guides what an efficient primary health care system to guide our data. I don't know why it's not coming on the screen appropriately. Let's get that HCPI framework to extract the data from the articles. So to respond to the questions, next, in low and middle income countries that were represented, of these, palliative many countries were still struggling to integrate palliative care in primary health care, in the primary health care system. That is because majority of the PHC system was unclear most of the countries. And outline only Chile, Indonesia, and India, particularly Kerala state of India, had actually a clear primary health care system, and they had integrated palliative care in this system, in this PHC system. Uganda was very exemplary in integrating palliative care across the entire country. This was really very amazing and very encouraging that Uganda was exemplary out of all these 9 countries to see that palliative care is integrated across the whole country in the general healthcare system. For some palliative care service integration was in the general hospitals and only in the oncology care. None of the low and middle income countries conform to all the domains of the primary health care performance initiative framework. So they hadn't really adhered to that framework, and that really shows us a gap on the weakness in our primary health care system. So question 2 and 3 is answered by that slide, approaches applied. So there were various approaches that were used, for example, lobbying for government support, and this included changing policies. For example, there were policies that had to be revised, like seeing that the nurses can be allowed to prescribe opioids, mainly oral liquid morphine, and that was exemplary for Uganda. So Uganda took the lead in that area. Access to essential drugs. Due to the lobbying of policies, nurses were able to support patients to access opioids in care infrastructures, like having a hospice that could support with lobbying of palliative care integration, and among other approaches that you see. All those were used. Next. The recommendations that given to accelerate the primary lobby for government support, revise national laws and policies to make them enabling, provide palliative care training programs for healthcare workers at all levels, improve access to opioids for palliative care use, allow task shifting of roles. And this is really very important, because we believe if nurses are trained and are empowered to take on certain roles, I think palliative care can reach very far. Many can access the services. Empower community volunteers to provide basic nursing care at home, but also invest in research. So that is really very important. So all in all, there are several contextual approaches of integrating palliative care into primary health care, and this can be adopted based on the setting. So integrating palliative care into primary health care using the Primary Healthcare Performance Initiative framework has the ability to address a nation's social determinants of health to promote universal health coverage. So thank you so much. I would like to acknowledge all these who supported the research. Thank you very much.
Now, Kamanya Winfred, are you on the line? That is the abstract number 6 on extension of eye health care services to the community.
Yes, please, I'm available.
Thank you so much, Winfred. You're welcome.
Yes, and thank you, Oka, for having shared my slides, please. This is Winfred Nakamanya, a registered nurse, and I specialized nurse from Rubago Hospital, and also on the NHCC team. I'm presenting extension of eye health services to the community. Next slide, please. Introduction. Rubago Hospital Clinic was targeting 30 patients from the usual numbers of 6 to 11. Because of these small numbers that attended to the clinic, there was very little amount of money collected by the clinic. So I, in consultation with the ophthalmology team, started a project so as to solve the problems above. Next slide, please. We looked at the objectives below: increasing patients' numbers through sensitization and awareness creation, increasing on the income through rendering services at affordable prices, hope the less privileged out there who do not afford hospital payments, methodology. Before accessing these communities, we used the village health team to inform people out there on when we would access these communities. When we arrived in these communities, we received these patients, assessed them, diagnosed them, managing minor conditions and referring complex ones to other hospitals, including Rubaga Hospital Eye Clinic. We carried out health education talks and sensitization, where we told the people on the preventive measures of various eye conditions. We also informed them about the services that were being carried out in the eye clinic. Next slide, please. Results. In the first month of September, we handed over 100 patients. The total attendance was 110, that was 100%. Majority were females, 63.6%, and the 36.4% were men. Those whose conditions were managed there and then were 72.7%, referrals being 18%. 9.9% of these patients were not given a diagnosis. The amount of money collected in the first 2 months was 230,000, of which was put on the eye clinic's account, yes. At the hospital eye clinic, we realized that the numbers of patients increased from the usual numbers of 11 to 18 per day in the following month. Recommendation. We urge the hospital administration and management to authorize that team to carry out reading glasses, as these were in high demand by the patients in the communities. Conclusion. In conclusion, it came to our notice that the numbers in eye clinic would increase. The amount of money gotten by the eye clinic would also be elevated, and then also there would be minimal or minimized eye conditions in the communities. Thank you so much.
Fred, thank you so much for that presentation and for keeping time. We will now go to the 7th presentation. And that is the nursing documentation, a dilemma in nursing documentation, dilemma in Uganda necessary, a case study of National Referral Hospital, Mulago National Referral Hospital, and that is Nakamate Mary and the team.
Thank you so much. I'm Nakari Grace. I'm waiting for the document to be shared. I'm glad to be part of this presentation. Should I project?
The slides are projected.
Okay. Okay.
My slides.
Wanted it in slideshow. Okay.
Please
in my
go
background,
ahead.
Yes. Nursing documentation started with Florence Nightingale, and it's either manual or electronic data, which primarily communicates patients' information to the healthcare team. And we see that nursing documentation as a pivotal part of nursing care has many implications for patient care in terms of safety. So when we look at the industry issues, we see healthcare reforms based on the nursing documentation. We look at the care coordination between the nurses and the other healthcare providers. It's based on the nursing documentation. We see a transition of care from one shift to another shift, depending on the nursing documentation. Patient safety safety, if you are to ensure safety of the patient, you must document care. Then in the medical reconciliation, we must document. Payments are based on the documentation. New models of care are informed by the documentation of the nurses. Patient and family caregiver engagement. If we are to integrate care, we must have information documented. In the collaborative practice, we looked at the doctor who presented about the care of the wound. Without information to share, you cannot collaborate. Then the problem statement. I summarized it that in Uganda, nursing documentation still remains a challenge. We see that in most government and some private health facilities, it's manual, and omissions have been observed. Duplication of documentation has been observed, and all these affect the patient outcome. The purpose of this study is to describe the nurses' perceptions and preferred features towards documentation of patient care at the National Referral Hospital. My research questions were, what are the nurses' experiences towards documentation of patient care at the National Referral Hospital? What are the nurses' recommendations for documentation in their patient care environment at the National Referral Hospital? When I review the methods, this was originally a mixed method, but I want to present the qualitative part of the study. It was a descriptive qualitative study that looked at the reflection on the facilitators and barriers and solutions to the documentation of patient care. And this was done by the nurses and midwives in the National Referral Hospital. The nurses were conveniently selected from the medical wards, 2 medical wards, 2 surgical wards, and 2 gyne and obs wards. How were they included in the study? The inclusion criteria based on the first, that I didn't talk about, the quantitative research study that was an interventional kind of study where a tool was introduced. The nurses documented. So all those nurses who participated in the documentation using that tool participated in the study. And those who were on night duty who could not be accessed did not participate. And a total of 37 nurses and midwives participated in the study. It was a self-administered, open-ended questionnaire that was used to collect data among the nurses. The data was analyzed using thematic analysis approach, where the researcher reflected through a series of exemplar quotations and developed sub-themes and later on themes. Approval was sought from Uganda Christian University and Mulago National Referral Hospital Research and Ethics Committee. The characteristics of the participants. Let me talk about the results. Their age range was between 28 to 58. 3 nurses were BSN nurses, 2/3 were registered nurses, and 1/3 enrolled nurses. 2/3 from the medical and surgical wards equally, and 1/3 from the obs and gyne. 8 respondents, that is 21.6, had an experience between 6 to 10, and 10% had an experience of 11 to 15 years, and the rest, 67, had an experience of over 16 years. The results indicated that 3 themes were identified after the analysis using thematic analysis: importance of documentation, challenges, and solutions. When I looked at the importance of documentation, influence on daily practice came out, professional roles, influence on institutional issues. When we look at the influence on daily practice, the participants indicated that documentation is good. And especially when assessing patients to identify their problems, it's a reminder of procedures to be done. Then they talked about the professional roles. The documentation informs the collaborative healthcare team about what has been done for the patient, thus promoting continuity of care. This indicated that really documentation was very important. Influence on the institutional issues. We look at, they stated that institutions' credibility is entwined with documentation. Then there were organizational issues where big numbers of patients were an issue, knowledge on documentation that some nurses didn't know how to document, training, that more training was a problem, that we needed training, especially even in the training schools, there were issues. Motivational support from the leaders. Now that we are talking about leadership, how do they motivate the nurses to document? And motivation from the interdisciplinary committee team, where some of our colleagues minimize the nursing documentation. So the solution was motivational factors, continuous encouragement from the leaders, and facilitating factors where use of policies in documentation. Then educational factors where like CMEs should be done, emphasis on documentation in schools was very important. Implications. There is need for the nurse leader organizational support. Nurses need to be supported at all levels, from the top management, the department, and the ward level. Development of a universal application document tool for hospitals and undergraduate nursing schools. Then we look at the long-term interventional studies on the effectiveness of the new tools that are available. Next slide. These were my references. Thank you so much for listening.
At the end of this. Now let's get to our last presentation in this session, and that is by Tumwesije Ambrose, who is going to tell us about the lived experience of multi-drug resistance patients receive. Tumwesije, please, the microphone is yours. Hello, is Tumwesije online?
Madam Moderator, I think Ambrose, Tumwesije, and team are not online. Maybe we can proceed to the next item.
They're not online? Okay. If they're not online, that means we are coming to the end of this session, but we need to react to some questions. During my session, I kept looking at the chat box and the Q&A. I didn't see a lot in the Q&A, but in the chat box, there was a few comments. Most people were appreciating the nurses for the great work done. You know, in the past, they used to think nurses do not do research, But time has come to tell that nurses are good at research, and I want to applaud all the nurses that have done such a wonderful job. Thank you very much for doing good pieces of research. And we are now talking with evidence. That is really great. There was one question towards Jackie, and somebody was asking, was there any challenge of water in these places? Maybe that could have on the cleanness of these girls. And I think that was the only question, unless somebody else has seen a question. Otherwise, we would ask Jackie to respond to that, and then the others are complement. After Jackie has answered, I'll then close the session. Jackie, are you there?
Yes, I'm here. Please
It seems
pardon me.
Jackie is also. Okay, the question was, great, yes. Jackie, thank you very much. Was there any challenge that compromised on the cleanness of these young girls that you with?
Yes, there was. So at the schools, I went to primary schools. So there was instances where these girls had to, there was one water source, a borehole, which they shared with both the community and the boys' side. So these girls had to probably line up for the water to access the water to use. That's one of the challenges that I saw. And of course, I also discussed with the senior women teachers and administrators of the schools. So some of these are in remote areas where there already is constraints of water and sanitation. So it wasn't something that could be handled immediately, though they promised to make it easy and to ensure that at least the schools have their own water sources so that these girls would have access to the water facilities. Thank you.
Thank you very much for responding to that, Jackie.
Sure.
When I look in the chat, actually, I don't see lots of questions in my session. So I'm going to say thank you very much, all the nurses that have presented. Thank you for being actively one as a virtual candidate that you rate. And I think going forward, we are going to have even better conferences. Now, I'd like to return the mic back to there is a question that has come up here, and it's saying, Dr. Grace, would it be meaningful to do a cooperative study to private and public facilities?
Thank you so much. I am sure there is to do that. When we get meetings like this conference has put us together, we can come together, like people who are interested in a given concept, and we continue with this research. Thank you.
Okay. There is also another comment which has come in. People are saying, somebody said that yes, documenting is important, but there is still a challenge of understaffing where you find 2 nurses on the ward with about 80 patients, and that poses a challenge when it comes to documentation. That is an observation and a comment that has come in.
Thank you so much. This is where
Yeah, and then somebody says nurses.
Yeah, Rose, you can call.
Yeah, but I think, and you'll see what is in the chat. So thank you very much, the organizers, for this meeting. It has been really wonderful for me to take nurses through this session. And again, thank you. I submit.
Thank you very much. Okay, well, that's fantastic. We're going to enter into our 5-minute break in a moment. But I just want to give thank you to people joining with us and watching the different presentations from Hoima, Lira, Mbale, Fort Portal, Lubaga, just all over the whole country. So that's absolutely fantastic. So we'll see you again in about 5 minutes.
Nursing, nursing, nursing.
So thank you very much to the student nurses and midwives in Zambia for that beautifully sung Nursing Now anthem. And now I'd like to hand over to Tracy Kamau, who has got some announcements for us.
Good afternoon, everyone. My name is Tracy Kobukindo. I'm a nurse and public health specialist. I'm also the chief editor for the National Healthcare Conference's blog site. I would like to thank all the stakeholders for making this conference possible. Thank you so much for all the support. Just a little bit about the NHCC site. NHCC is a knowledge sharing platform, and in that vein, we are glad to share with you all about the NHCC blog site for nurses and midwives in Uganda. It is a platform we have utilized to share stories, articles, and research by nurses and midwives in Uganda. We are so blessed to have a team of 5 editors who are dedicated to working with writers like you to write, refine, and edit their pieces for publication on the site. A special shout out to our editors, Dr. Rose Clark Nanyonga, Miss Mary Nakalanda, and Mr. Elisha Okaisu, as well as Mutewa Laban. These editors are all edit, review your pieces for publication, so really encourage you to write as much as you can about anything and everything. We have so far published over 10 articles on the blog site, and I encourage you all to go and check out the NHCC site. It is hosted on the NHCC Uganda website. We appreciate all those nurses and midwives who have so far taken time out to write and share with us their work. And I'd like to encourage you all, and I look forward to receiving even more pieces from the nurses and midwives that are attending this conference, and also those that are unable to. We hope that you're able to share. As this is a virtual conference, I do hope that you're remembering to stand up, walk a bit, stretch during the breaks, and also take precautions, social distancing for those that are attending in one room, and also don't forget your masks. At the end of the announcement. Enjoy the rest of the afternoon. Thank you.
Thank you very much. Now we have a presentation from stakeholders from Seed Global Health. So Dr. Brittany, we will hand over to you for your presentation. Thank you very much. Okay, so if Dr. Brittany is not available right now, I think what we're going to do is move over to our next session and hopefully move back to her. So we've got an interactive session with our group of nurse leaders in the Christian University in Mukono. So handing over to you. Thank you very much. So just while we wait for the speakers to become available, so could we hear from somebody from Mbale, please? What is your big takeaway from the meeting so far? What have you enjoyed? What have you learned? Mbale Hospital. And while Mbale is getting ready to give us a comment, can we ask the same question to Mbarara, please? What their takeaway is from the meeting, what they've enjoyed, you know, what they've learned. Mbale Regional Hospital, do we have anybody to give a comment, please?
Yes, yes. Yeah, this is Mbarara Regional Referral Hospital.
Hello.
West Barbados. We are very grateful to be in this conference, and we thank everyone that took part in organizing. We are happy, we have enjoyed the presentations, and we really liked the researchers, more especially on part of documentation. We've seen that it affects all of us, and if we put in much effort to change our attitude, I think documentation will be really be done effectively. Otherwise, we want to thank everyone that have took part in organizing this international conference. Thank you so much. And we are still listening, we are still with you. I thank my colleagues that have come to attend. Let's appreciate the conference organizers. Thank you so much.
Thank you very much for that. So over to Mbale, please.
Good afternoon, everybody. This is Mbale Regional Referral Hospital. I would like to appreciate, first of all, the organizers of this day and tomorrow. I want to thank my colleagues who have attended the conference. It has been a very golden time for us. The impossible has been made possible. Distance is not a barrier. In fact, what is happening in Kampala is happening in Mbale. And to my colleagues, they have really discovered what they didn't know. They were asking what is Zoom, and I said, come and see, come and hear for yourselves. So today, we are so happy for the presentations. We have learned a lot, and the request is, I wish we could all share these presentations. We share with the colleagues, because learning is always a process, and learning is power. Knowledge is power. Thank you so much, and we wish to continue booming and learning more from our colleagues. Thank you so much.
Thank you, Mbale. That's fantastic. So could we have somebody from Lira Hospital to speak next? And then after that, Fort Portal, please.
Thank you. Hello. Thank you very much, Mr. Easton, live from Lira. In Lira, we've had a fantastic time. The only problem we had here was network issues, but we want to say thank you to the arrangement and the program. We have basically benefited a lot, and we look forward to being there tomorrow to listen and learn more. Yes, this is Edson live in Lira Regional Referral Hospital. We have had a good day, and we have enjoyed a lot of the presentation, especially the abstracts of research from the nurses, and also the teaching from the doctor, Dr. Thomas Serena. We had good time to learn about wound care, and the nurses here are appreciating, and we are looking forward to joining in the morning throughout the day and be part of this noble cause for rising up the profile of nurses all over Uganda. Thanks a lot.
Thank you very much for that. So can we go over to Fort Portal now? Or is Arua available,
Hello.
please? Can we speak to Arua? Thank you.
Yeah.
You just need to unmute to speak for us, please. So anyone to speak from Arua, please?
Good afternoon, everyone. Hello.
Good afternoon.
Good afternoon. My name is Santabu, Principal Nursing Officer, Rural Regional Referral Hospital. We are delighted to be part of this discussion. Our sincere appreciation to all those who were able to follow it, although we had network challenges. This is our first attendance. We did not attend the first conference. We are getting organized in ICT. Now we are set that we will continue attending the following. Thank you.
Thank you very much. And a call out to Rubaga Hospital. Anyone there who would like to speak to us, please?
SPN of Vida has something to say. Hello?
Mbalo Regional Hospital.
The SPN of Vida Regional Hospital. Hello?
Today we are practicing with the NLB. We will now have our full members. We have constituted our union members.
Can Masaka say something, please?
You unmute, see.
Thank you for everybody who commented. So now we're over onto our next conversation with the stakeholders from Seed Global. Thank you very much.
Hello? 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 Molly Eriki from Uganda Private Midwives Association, the Vice President. Hello? Hello? Hello?
We can hear you.
Thank you very much, Molly Eriki, Vice President, Uganda Private Midwives Association. This is beautiful, and the presentations were really giving a lot of knowledge. And I want to thank particularly the one who presented on documentation. Documentation is a big problem, and we should not take it lightly. Whether we are few in the ward or we need to do something about it, we need to work it around the clock and see if there is only one nurse or two, how do we manage it? Otherwise, thank you very much. Over.
Oh, thank you so much.
So thank you for all the comments from all the regional referral hospitals. Very much appreciated. Makes it all feel very worthwhile, and we'd love to see you all in the flesh next year. So God willing, that's going to happen. So we'll now move on to our next speaker, and over to you. Thank you very much.
Good morning. Sorry, did you say that it's time for Seed's presentation?
Yes,
We're a bit ahead
indeed,
of schedule. Okay.
Dr. Brittany, please proceed. Thank you very
Perfect.
much.
Good morning or good afternoon, everyone. I'm Brittany Vandewater. I am a pediatric nurse practitioner and a TB researcher from the United States. I work at Harvard Medical School as an instructor of global health and social medicine. And then I am also the interim director of nursing and midwifery for Seed Global Health. And I've been with Seed as their associate director of pediatric nursing for about 6 years. I'm just going to share my screen. Am I allowed to? Start. Okay. Okay, great. Can you see that?
Yep, we can see that. Thank you.
Okay, so yes, I'll be talking today about some of the research I've done in South Africa about a tuberculosis prevention cascade, and this is in the rural Eastern Cape, the area known as the Transkei or the homelands. So first, I'd like to just welcome you all. Thank you for inviting me. I'd like to acknowledge some of the representatives from the Ministry of Health and the Ministry of Education and Sports, different senior principal nursing officers from the regional referral hospitals, and everyone else on this call today. On behalf of Seed Global Health, it is a real pleasure to be presenting at the second National Healthcare Conference, which unfortunately is being held virtually this year. This, as you all know, has been declared the Year of the Nurse and Midwife by the World Health Organization. And I'd like to congratulate and thank the nurses and all the midwives for their tireless efforts at the front line. Due to COVID, we haven't been able to celebrate physically the great achievements of nurses and midwives as originally planned, but luckily through technology, we have been able to hold virtual activities such as this. As I mentioned previously, currently I'm the interim director of nursing and midwifery for Seed Global Health, which is a nonprofit organization based in Boston in the United States. That's our headquarters. Prior to my position with Seed, I was a nurse educator with Seed Global Health and the US Peace Corps, and I was a nurse educator in Malawi, teaching alongside faculty at Mzuzu University from 2013 to 2014. I have traveled and worked in Malawi, Lesotho, Rwanda, Kenya, and have extensive experience living and working in rural South Africa. Unfortunately, I haven't made it to Uganda yet. I was supposed to, but ended up having a baby instead. So those plans got delayed. Global Health has a vision of a world where every country has a strengthened health system and a robust health workforce able to meet its population needs. Currently, SEED works in Uganda, Malawi, and Zambia, and we also support beginning initiatives in Sierra Leone and Eswatini on a much smaller scale. In Uganda, SEED Global Health works with its partners, including the Ministry of Health, the Ministry of Education and Sports, and many universities, including Makerere University, Embrar University of Science and Technology, Mooney University, Lira University, and Busatima. And this is to really help build capacity in medical and nursing education in the areas of emergency care, maternal, neonatal, and child health. At SEED, we also recognize that education alone is not enough to strengthen a health system. Thus, we have a partnership with the Ministry of Health, hospitals, and professional associations, and are supporting the practice and policy aspects to strengthen nursing and medical professions in Uganda through conferences and other initiatives to advance the profession. So that's about SEED Global Health. And at the end, I'm happy to take questions. So as we're going through this, if you have questions at the end, I will look in the chat or listen to. So I want to talk a little about tuberculosis, which I know a few of the other presentations have been on. So first off, TB is the #1 infectious disease killer worldwide, claiming more lives than HIV. And care cascades are useful frameworks, especially for diseases when multiple interventions or steps of care that people go through from initial diagnosis to achieving a desired outcome is achieved. So I work with a group called the Zero TB Initiative. It's a group made up of individuals from Harvard and a nonprofit called Advance Access and Delivery. And it's a coalition of policymakers, clinicians, municipalities, and local governments and civil society groups, which are committed to creating islands of TB elimination around the world using a comprehensive set of initiatives to search, treat, and prevent TB. So this study that I'm going to talk about today focuses on the prevention cascade among household contacts of TB patients. So this slide is a picture of the Zero TB Initiative TB Prevention Care Cascade Indicators. So these are the things we use to measure if we are doing well or not doing so well. And it's really a way that has helped operationalize in a way to devise measurement tools for program evaluation. So the first step is to enumerate the target population. And this must be established in order to calculate the number of evaluations completed among the target population. Then, to determine the TB disease diagnosis, one can calculate the number of individuals with TB disease divided by the number with complete TB evaluations. Step 3 evaluates the prescription, which is the number prescribed preventive therapy over the number eligible for preventive therapy. Step 4 measures the uptake of preventive therapy, and step 5 evaluates the completion of preventive therapy. And here, finally, step 6 evaluates TB-free survival 1 year later of those deemed not to have TB disease at initial evaluation. So our objective is to identify steps of the TB preventive care cascade, which could be calculated from routinely collected data among TB patients at a rural hospital in Eastern Cape, South Africa, prior to the implementation of a novel TB program. So we're actually planning a much larger TB program initiative. And so this was all to kind of get baseline data. So a secondary aim of this was to also identify the amount of missing data from the current charts that are being used. And we wanted to enumerate each step of the care cascade, allowing us to direct appropriate interventions as part of this novel program, specifically looking to close the gap in losses among household contacts in the TB preventive cascade. And this was a retrospective study, and it took place in the KSD subdistrict, which is a very rural, underserved, and poor community with unemployment rates nearly 80% and access to running water in less than 50% of the households. The hospital that we looked at serves 14 primary care clinics and 2 community health centers. And the hospital provides basic hospital and primary healthcare services to a population of roughly 125,000 people. Data were abstracted from TB charts, including how many patients reported contacts being screened for TB, and if those contacts started preventive therapy. Finally, we used SAS, a data analysis tool, to calculate proportions and for analysis. So what did we find from the study? We reviewed a total of 1,722 charts of drug-susceptible TB patients. The mean age of index patients was 34.5 years, with half of them being female. Most patients were newly diagnosed with no previous episodes of TB. The majority of patients had pulmonary TB, and 31% had extrapulmonary TB, while 4% had both pulmonary and extrapulmonary TB. And the types of extrapulmonary TB included lymphatic, abdominal, pleural, and TB of the spine. 90% of index patients identified at least one close contact in their medical chart. And this ended up being a total of 7,548 contacts identified, with a median of 4.9 contacts per index patient. Among all contacts identified, 39% were screened for TB. And when we say screened, we are talking about a 4-symptom screen. So this doesn't include X-ray or additional evaluations. 15 individuals started TB preventive therapy, and 122 started TB treatment. So using this Zero TB initiative framework, it shows us that only 39% of household contacts were screened for TB, and less than 1% started TB preventive therapy. And although it's not noted on this figure, as I just said, an additional 1.6% of people started disease treatment. So as this figure shows, a major challenge was that many variables collected had missing data, pointing to the need for better documentation for TB close contacts. Many steps of the Zero TB initiative preventive care cascade were not possible to calculate due to the charts either not having space or relevant questions being asked to record this vital information. So in conclusion, finally, in this analysis, we saw that few household contacts are screened or started on TB preventive therapy. And there was a large drop in number of contacts identified to number of contacts screened, which is an area for significant improvement. Many contacts, some of the reasons we think this is true is that many contacts who were identified and not screened, it's likely due to difficulties in patients bringing family members to the clinic or hospital for screening, or for hospital and clinic staff to access transportation to get into the community. Another large drop was from screening to preventive therapy uptake. However, it's worth noting that at the time these data were collected, only children under 5 and people living with HIV were eligible for TB preventive therapy. Thus, not everyone screened was eligible per South African guidelines. And unfortunately, we were unable to determine an accurate denominator for those truly eligible, such as individuals with HIV or children under 5, because in the charts, the ages of contacts were often not listed and HIV status of contacts is not asked. So we realized that conducting a baseline assessment prior to an intervention can really provide clarity both to planning what variables researchers will collect in order to decrease missing data, and where to emphasize program investment in planning to maximize impact and reach. So collecting the necessary data to monitor steps in this TB prevention care cascade is essential to improving quality of care for patients and contacts, because without it, it becomes very difficult to measure improvements in care, let alone gather these baseline data. So perhaps some of the things we brainstormed about was maybe initiating registers or individual charts for close contacts, which could alleviate some of the missing data and the methodological issues which we encountered. So once again, I thank you for the opportunity to speak. I'm happy to take questions, and I just wanted to recognize that this was funded by the Robert Wood Johnson Foundation. Thank you.
Thank you, Dr. Brittany. And thank you for being able to come in earlier than the scheduled time. And thank to all presenters that had come in earlier due to technical challenges. Now, right now, I'm reliably informed that our guest of honor is online in person. Dr. Tafina Musene, Commissioner BTVET, that is Commissioner of Business, Technical, Vocational Education and Training, and the Chair, Nurses and Midwives. Dr. Musene is a household name in the BTVET world where I happen to belong. She has championed a lot of reform in the sector. She's a mother and a role model. Allow me to call Doctor right now to officially open this conference and deliver her remarks. Thank you, Doctor. Over to you.
Thank you very much, moderator. Moderator, I'm representing the minister, supposed to be the guest of honor at this meeting, the Honorable Minister of State for Primary Education, and who was delegated by the Minister of Education and the First Lady of the country. Guest of, coordinator and dear participants at the conference, good afternoon, and we thank God for keeping all of us alive. I'm going to request that you allow me to read this speech verbatim, because it is not my speech, but for the minister. The minister has given apology, which she provided even through writing to the chairperson of the organizing committee of this conference, and she was not able to be with us today because of other official duties. I think all of us in the country appreciate what the country is going through today, and so is even the Minister of State for primary education. She was also willing to be with us, but this morning she got another demand assignment that has this speech was supposed to be given in the morning, and therefore she started by greeting you. It is the year of nurses, and I want to welcome you all to the second National Healthcare Conference. This conference is designed to promote world health development through knowledge sharing, so that nurses and midwives can realize their contribution towards the achievement of universal coverage. When the founder of modern nursing, Florence Nightingale, and Mexico defied the status quo, they advocated that nurses need education, training,
tutoring, and to be taught skills so that they are well equipped to manage their patients. 200 years later, nursing has evolved and is now diverse and covers more than 100 specialists to date. In Uganda, nursing and midwifery curriculum, we have some of these specialties and different levels of education and training. Through hard work and advocacy, nursing and midwifery education in Uganda moved from the certificate to diploma and later to degree. And as we talk now, we have masters in our universities and many nurses have acquired PhD. The complex and changing healthcare environment within which nurses and midwives operate require this level of advanced knowledge, skills, and competences, and allow us to develop an enhanced skills mixture and strong workforce for the country. The Ministry of Education and Sports, alongside with the Ministry of Health, recognizes the need to expand the nursing and midwifery curricula to include more specialty. This is a key strategy which will allow us to diversify the workforce and to address the changing health needs of our society. For instance, during this COVID-19 pandemic, we have prioritized the need for training and over 300 specialist critical care nurses who are urgently needed to look after COVID-19 patients have been prepared. We have public health nurses who work with communities to educate people about healthcare issues, improve community health and safety, and increase access to care. More than any other time in our history, we need the public health nurses to reinforce public health measures needed to stem this pandemic. In the other specialties, we have cardiology, cardiological nurses, palliative care nurses, nurse educators, and psychiatric nurses who treat patients who suffer from a variety of mental health conditions such as bipolar disorders, depression, and post-traumatic stress disorders. We also have some pediatric nurses and midwives who have specialized in pediatrics and have devoted their knowledge and skills to cater for children from infancy through the late teen years. Given all these emerging areas of specialization, it is clear that the relationship between nursing education and clinical practice is critical and critically important. Education informs and improves clinical practice. In the same manner, clinical practice experience and evidence are needed to inform how future nurses and midwives can be educated and specialized. Ministry of Education and Sports is impressed with what nurses and midwives are doing with the knowledge acquired during training, in particular in the area of conducting research that informs quality care and expands nursing and midwifery knowledge base. As you know, non-communicable diseases accounts for nearly 33% of adult mortalities, and more people are here and globally are living longer with comorbidities. This underscores the need to increase capacity and have more specialists in Uganda, such as transplant nurses, diabetic specialist nurses, oncological nurses, trauma and emergency nurses, who generally work in emergency rooms and other chaotic environments and provide care for urgent solutions. We also need respiratory nurses who work with patients with breathing problems like lung-related issues, which include asthma, tuberculosis, emphysema, cystic fibrosis, and lung cancer. We also need urological nurses who treat patients with urinary health conditions and perform urinary health exams and diagnose problems like bladder incontinent. Wound and stoma nurses. These nurses care for patients with wounds caused by medical treatment, diseases, or injury. They also provide for surgical care and cater for patients post-operatively. I'm pleased to see on the program for this conference that we have specialties in medical surgical areas. And I'm also very happy that Dr. Samson, who has already presented, by the time she wrote this speech, it was before she was going to present, to be here today with us to make capacity development for our country. So it is essential that the nurses and the midwives again become competent and skilled in all areas of health service delivery for effective service delivery in the health sector. We at the Ministry of Education and Sports will continue to update the curricula for nurses and midwifery training so that it is in line with the health care context demand. As a ministry, we embrace this initiative for nurses and midwives to share knowledge and learning, and we will continue to work together with the relevant stakeholders to achieve standardized and improved clinical care delivery across the nation. It is good to see that those who have carried out research here in Uganda for academic purposes are willing to share their findings from their research to inform and improve care. This is particularly important, especially for advanced nursing care. In conclusion, ladies and gentlemen, thank you to the organizers for this conference, for making it possible for various nurses to join this conference at the various hospitals throughout the country. These nurses and midwives are in the practical clinical areas and ready to learn and implement directly what skills they have gained from this knowledge sharing platform here and across the world. Nurses and midwives have worked tirelessly to maintain our health care facility before and during this pandemic. We thank you for your continued dedication and service to the country. We thank you for being available and working with the Ministry of Health and all health providers to ensure that you are on call 24 hours. And as a country, we will continue supporting you in your endeavor. Thank you for listening.
Thank you very much, Dr. Safina. And I'm quite sure that you had to sacrifice something on your schedule to be here, so we cannot take that for granted. Thank you once again. Now, ladies and gentlemen, earlier on, I had a rooster in someone's background. What that essentially means is that we are working through the lunch hour, and I want to thank you for your resilience. But I can assure you that we are about to come to the end. And so let us quickly move on to the next item on our agenda. And that is the presentation on moving the fraternity forward, adopting advanced technology and research clinical practice. It's going to be an interactive session with nurse leaders, and the moderator is Dr. Grace Nakate, lecturer, Uganda Christian University, Mukono. Take it away, Dr. Grace. Thank you.
Thank you so much. And I want to thank the participants for consistently sending messages and appreciating. And I want to thank the organizers of this National Healthcare Conference that has enlightened us and that has brought us together in the year of the nurse. So when we look at moving the fraternity forward, adapting advanced technology and research in clinical practice, I see that there is a changing landscape of the healthcare system and the changing profile of the population that requires the system to undergo a fundamental shift. Okay, let me put on my video. That requires us to undergo a fundamental shift to provide patient-centered care. That means provide a seamless care. As our patient enters the hospital, we should give quality care. As the patient continues to receive care, it should remain quality care until the patient is discharged. So this will enable, or we should need to enable all health professionals to practice to the full extent of their education, training, and competences. Many nurses have upgraded, and we need to tap into this to see that we improve our practice, we improve the care we give, and we need to foster the interprofessional collaboration to enable the healthcare system to provide high quality care and reduce errors and increase safety. So providing care in this way taps traditional strength of the nurses in our nursing profession. So our leaders need to come in here and work with the nurses who are now knowledgeable, who have done research to improve care. Thank you so much. I want to invite all the leaders in this forum to talk about moving fraternity forward, adopting advanced technology, and research in the clinical practice. Thank you so much.
Thank you, Doctor. And can I invite then the interaction from nurse leaders? Any questions to the doctor?
Okay, thank you.
If there is none, you can post them in the messages, and we can handle them as we go on in the interest of time. Now, the next item on our program is the closing remarks. And this will be presented by Dr. Rose Clark Nanyonga, VC Clark International University and patron NHCC Uganda. And it's on utilizing research and evidence-based practice. Now, I can assure you, Dr. Clark, from the last conference, I remember the caterpillar analogy. It was quite catching for me. And I'm looking forward to something I take home today. Thank you.
Thank you very much for your kind words. All the honorable guests in the room, protocol observed. Thank you for having me here today. I have some significant noise in the background, and I hope that it's not too distracting. I want to go back a little bit to actually Dr. Grace. I feel like we should be ashamed if we do not have questions for her when she passionately talks about how we can move the fraternity forward, either through research or clinical practice or innovative strategies that we have not thought of before. Hold on one second. Let me see if I can stop the noise in my background.
Thank you, Dr. Clark. I think there is something that we can't say about the technology, about the research our nurses have done. How can we use this research and technology in improving clinical practice?
I apologize. I've had to stop whatever was going on in the background. So Dr. Grace, I apologize because I was listening to your presentation, and we should have a lot of questions. One of the things that I would like to talk about today is encouraging the nursing fraternity to ask questions. When we ask questions, we are able to do research. When we conduct research, such as some of the examples we've seen today, research in palliative care, research in prevention of post-surgical infections, research in menstrual hygiene management for young women so that they can stay in school, the extension of eye services to the community, nursing documentation, a core component for continuity of care, and so on and so forth. All the nurses that have presented this afternoon have had to sit down and ask questions. Ask research questions about the clinical relevance of a particular intervention, ask a question about their usual practices within the clinical environment, ask questions about the interactions that they have constantly with patients, pivoting away from what they do usually to ask, is this what we are supposed to be doing? Could we do things a little bit differently? And could we do things better? We need to be asking questions. And of course, those questions have to be informed by what we are experiencing, by what we are reading, what has been published before, what evidence is available to us. And it doesn't matter whether we work for a major regional referral hospital. I see that there are a lot of nurses in the regional referral hospitals here, Masaka, ICU, Rubaga, Mbarara, Lira, and so on and so forth, Jinja, I think they were also here. We need to be asking questions every single time we engage with a patient. We need to be asking, is the nursing package and the nursing care and the nursing narrative and the nursing dialogue that is occurring grounded in best practices, in the most current evidence? And I think sometimes we wonder what really constitutes good evidence. You know, some of us don't have access to journals. Your hospital probably hasn't subscribed to a single journal. Maybe if they have subscribed to a single journal, it goes to the medical director's office, and the SPNO doesn't have access to that work. And sometimes you don't have access to data, you don't have access to a computer where you can actually look up the most current evidence and so on and so forth. So I do encourage this, and I make these recommendations in the context of recognizing that you may not have everything that you need to be able to implement evidence-based practice. What is it anyway? Evidence-based practice means that we are integrating available evidence or research or clinical expertise or experiences or patient preferences to individualize care and promote effective decision-making. So that means that even if you don't actually have access to a journal, access to a paper, access to a library, such as what we have at the universities, you still have a lot more evidence at your fingertips with which to make decisions and with which to actually work. When we look at the available evidence presented to us today, majority of this work, it was within the clinical setting. These nurses sat down and explored a problem within their means, right where they work, and then they wrote it up and published it for all of us to understand that this is what is going on. And hopefully they are able to now escalate some of those interventions into a critical component of what I want to leave with every nurse here today, which is nurse-led interventions. We know that we do not have enough healthcare workers in the country. We know that we do not have enough doctors in the country. We know we do not have enough nurses. However, we know, as Sister Catherine O'Day mentioned at the very beginning of this conference, that the available workforce of nurses and midwives make up at least 73% of the healthcare system, and they are an unrealized and untapped potential. And I think for me, that's where we have failed to make smart investments when it comes to recognizing that nurses are the majority, and therefore, if we want to roll out evidence-based practices, we need to tap into their knowledge, their capacity, their availability, and their numbers to be able to do this. So this is a powerful problem-solving tool going forward, is to be able to tap into that, but also for the nurses to recognize that actually they can provide some solutions to the problems they encounter every single day. That the Minister of Health may not be able to come to your unit to actually figure out that there is a wound problem. She may not be able to understand that there are problems with palliative care in the community where you live. She may have some statistics that are reported to her, but the nuances of what make those interventions work are all knowledge that the nurses actually hold. So nurse-led interventions going forward become a critical component of moving the fraternity forward. As the Minister of Education and Sports in her speech rightly points out, all the specialty areas and the data that we are getting for chronic illnesses, for example, require nurses to engage and begin to develop interventions that they themselves can lead. And one way to strengthen our ability to be able to lobby for repositioning of the nurse and the midwife in this country is to be able to engage in research, is to be able to produce the evidence, unrefutable evidence of how these interventions work, how these interventions can be strengthened, and how these interventions require, more importantly, require investment, so that nurses are given the amounts of money and the funding that they need to be able to advance their questioning and to be able to advance their intellectual experiments in research and to be able to advance the publication and the dissemination of this evidence so that it can inform routine practice and we can recreate care pathways that are very, very much contextualized but are informed by the knowledge of the nurses who are responsible for the majority of that care. So if you forget everything else that I say today, ask the right questions. 2, remember that nurse-led interventions are a way for us to strengthen what we do, what we communicate, how we lobby, and how we can ask for more investments to advance evidence-based practices within the areas where we work, whether that's a community, a regional referral hospital, or a clinic, and so on and so forth. So I want to thank you for giving me audience and a platform to speak with you. I am happy to welcome questions. My email can be posted on the site for those of you who may have additional questions about how they can establish a particular framework of evidence-based practice in their own clinical setting. Ask questions, review the literature, appraise critically the evidence available to you, and apply what you can, and then review to see if what you are applying and what you are implementing is actually working. I thank you, the organizers of this conference, for giving us a platform to be able to raise the profile of nurses and midwives in this country, to consider it important enough for us to sit here all day and listen to the amazing work that is being produced by the nurses on this forum. So thank you so very much. I submit back to you, Mr. Mhumuza. I don't know if you are the one hosting at the moment. I submit back to you. Thank you very much.
Thank you, Doctor.
Thank you. Okay. Thank you, Dr. Rose. That's absolutely fantastic. Oh, so, I mean, first, what we'd like to do is thank the Nursing Now coordinator, Mrs. Odeke, the commissioner, Dr. Safina, all the abstract presenters, all the leaders at the hospitals, and we'd love to hear more from them tomorrow, and from our stakeholders, including Seed Global Health, the Ministry of Health, the Ministry of Education and Sports, and the Uganda UK Health Alliance, and Zone 1 here in London, and to Dr. Thomas Serena and the many more speakers that we had. We thank you for your time and efforts, and especially the most important people, all the participants, because without you, this wouldn't be possible. So thank you for taking time out of your busy schedules to attend. We'd like to thank the NHCC team, and there is more in store for tomorrow. We're going to be starting at 11 a.m. East African time. We're going to be hearing from people such as Dr. Catherine Hanaway and her team, which I'm hoping we're on board today to watch this. Professor Amaswa, the ambassador, amongst others. So we do apologize for any technical areas. You know, as they say here, every day's a school day, we're all learning, but all the pandemic's done is make us stronger, more knowledgeable, more resilient, and develop more resources. So apologies for not having heard from Judy from the, the Africa rep, but for the NNC, but maybe tomorrow we will be able to hear from her. And we thank you, Oscar, for all your help and assistance. That's been absolutely fantastic. And the whole team that's put this together behind the scenes, obviously without you, this whole event wouldn't have happened. Team Machuka. Okay, so thank you very, very much. Enjoy the rest of your day. Continue the conversation amongst yourselves, and let's uplift the whole profession. So, and thank you to Tim as well. Thank you very much.
Thank you, Matthew, and see you all tomorrow.
Thank you and have a good afternoon.
Jumuiya Afrika Mashariki, tuwezeshe kuishi kwa amani, tutimize na malengo yetu. Jumuiya yetu sote tuilinde, tuwajibike, tuimarike. Umoja wetu ni nguzo yetu, idumu jumuiya yetu. Uzalendo pia mshikamano viwe msingi wa umoja wetu, na tulinde uhuru na amani, mila zetu na desturi zetu. Jumuiya yetu sote tuilinde, tuajibike, tuimarike. Umoja wetu ni nguzo yetu. makini, tujitoe kwa hali na mali, tulijenge jumuiya bora, jumuiya yetu sote tuilinde, tuajibike, tuimarike, umoja wetu ni nguzo yetu, idumu jumuiya yetu.
Thank you,